Hello friends, welcome back to my channel. In this video, I will be talking about main cartilage forming tumors. So let's get started. Chondroblastomas are benign bone tumors, rare and arise in second to third decades of life. The common location is epiphysis of long bones. On X-ray, well-defined lucent lesion with thin sclerotic rim with or without matrix calcification is noted, which may extend to metaphysis. Grossly, these tumors are well circumscribed, white, blue, gray, and firm, microscopically round to oval chondroblast with chicken wire calcification, presence of chondroid matrix, presence of osteoclast type giant cells are seen with no atypia and only few mitotic figures. The treatment is excision or curettage with or without bone grafting. Talking about enchondromas, these are benign hyaline cartilaginous tumor that arise from the medullary cavity or rarely from the bone surface. And when they are arising from the bone surface, they are known as juxtacortical enchondromas. They are usually diagnosed in individuals of 20 to 50 years of age, typically appear as solitary lesions of bones and head bones of hands and feet, and when they are in multiples, they are in form of syndromes like Ollier disease and Maffucci syndrome. On X-ray, there is a radiolucent lesion with sclerotic rim with central irregular calcification and an intact cortex. Grossly, these tumors are less than 3 centimeters, gray, blue, and translucent. And on microscopically, they are composed of benign chondrocytes embedded in well circumscribed nodules of hyaline cartilage. The peripheral portion of the nodules may undergo enchondral ossification, while center may calcify and become infarcted. Here you can appreciate the X-ray image of enchondroma and the micrograph of enchondroma. Osteochondromas are benign cartilage cap tumor arising from the bone surface, also known as exostosis. They can be sessile or pedunculated. 85% of them are solitary, and 15% of cases are seen as multiple hereditary exostosis syndrome. They develop from the enchondral region bones and arise from metaphysis near the growth plate of long tubular bones. They are associated with X1 and X2 gene mutations. Grossly, the size ranges from 1 to 220 centimeter, and microscopically, the cartilage cap is composed of hyaline cartilage covered by perichondrium. The cartilage recapitulates the growth plate and undergoes enchondral ossification. The newly formed bone makes inner portion of head and stalk. The cortex of stalk merges with the cortex of host bone, resulting in the continuity of the medullary cavity of the host bone and osteochondroma. The treatment is simple excision. Here in the X-ray image, you can see the osteochondroma as I have depicted by the arrow and the cartilaginous cap of osteochondroma in the micrograph. Talking about chondrosarcoma, well, it is a malignant tumor producing cartilage. Second most common matrix producing tumor of bone after osteosarcoma. There are few subtypes like conventional, dedifferentiated, clear cell, and mesenchymal type. The conventional chondrosarcoma accounts for about 90% of the cases, and they arise in fourth decade, and the male is to female ratio is 2 is to 1. About 15% are secondary, arising from a pre-existing osteochondroma or enchondroma. They are associated with X1 and X2 mutations, IDH1 and IDH2 mutations, and silencing of CDK in 2A. The axial skeleton is affected, especially the pelvis, rib, and shoulder. On X-ray, popcorn-like calcification, lytic lesion, endosteal scalloping, and cortical erosion with soft tissue extension is noted. Grossly, these tumors are bulky and composed of gray-white translucent cartilage with gelatinous or myxoid areas. Focal calcification are present with central necrosis creating cystic spaces. Extracortical extension is common. And on microscopy, these tumors vary in cellularity, cytological ATP, and mitotic activity, and are designated from grade 1 to grade 3, which correlates well with prognosis. The grade 1 tumors have low cellularity and contain neoplastic chondrocytes with plump vesicular nuclei and small nucleoli, whereas grade 3 have high cellularity, extreme pleomorphism with bizarre tumor giant cells, and frequent mitotic figures. Here you can appreciate the gross image of the chondrosarcoma and the macroscopic appearance of chondrosarcoma. The treatment of chondrosarcoma is wide surgical excision. The 5-year survival rate for grade 1 tumors that rarely metastasize is about 80 to 90%, and 70% of grade 3 tumors metastasize hematogenously, typically to lungs, and have a 5-year survival rate of less than 50%. I have covered main cartilage forming tumors in this lecture. Don't forget to subscribe to my channel. Thanks and bye for now.